there has been a bunch of updates about bromodomain inhibition in myelofibrosis in the last larger meetings in either European Hematologic Association or American Hematologic Society. So there was basically a drug that is investigated in the MANIFEST trial. There was a phase 2 study with a quite complicated design, which had actually patients from monotherapy, so patients who failed Ruxolitinib, and then went through the suboptimal responders in actually the arm 2, where the drug was added to patients that have been on Ruxolitinib and had suboptimal response, and then in patients up front. So that actually last arm moved on to the current phase 3 MANIFEST-2 study, which is actually randomizing patients who were newly diagnosed, never treated, in anito therapy to either Ruxolitinib placebo or Ruxolitinib Pelabresib. So while we talk about Pelabresib or BET inhibition, it is definitely an important OS and target in patients with myelofibrosis. It's a downstream consequence of JAK-STAT activation that happens in these patients and definitely does upregulate NF-kappa B genes, causing increased cytokines, really differentiation problems with the megakaryocytes and erythroid lineage that then lead to consequences of cytopenias. And we have learned that the cytopenias has actually become more a problem of patients with myelofibrosis than they are not addressed by JAK inhibition on its own. Indeed, they are actually worsened by that. So there is been a search for agents that could actually help with that. And then the MANIFEST trials actually showed then in a monotherapy where the agent is used as a single agent after JAK failure, intolerance, or refractority, where actually 56% of these patients comprise really refractory patients. Then there was improvement in anemia, especially. That was actually one of the arms because that arm had two cohorts, transfusion dependent and transfusion independent patients. Although the transfusion independence conversion was not that great, about 20%, 16 actually, but the improvements in hemoglobin, which also relates to patients who are transfusion independent at the beginning, was achieved in quite nice 30% of these patients. That was even more significant in the add-on approach, where again the conversion from independence to dependence on opposite was again only 16%, but over 50% of these patients achieved less than 50% decrease of need of transfusions, which is definitely a significantly relevant point. And then, of course, these studies always focus on the improvements of spleen symptoms, which is the major point for myelofibrosis patients. And we have seen in the monotherapy that the spleen improvements could be kind of like modest, up to 20% only. The symptoms are a little better in 30% of these patients. The add-on approach didn't show us much more, 20% for the spleen volume improvements, 40% for the symptoms. But for the upfront combination, which is actually interesting, that's why it led to the MANIFEST-2, was the upfront seen in improvements of spleen, which was noticed in 68% of these patients. So if we got back to Ruxolitinib single agent, which led the agent approval in the COMFORT and COMFORT-2 studies, that was noticed in 42%. So almost 70%, it's kind of like better that we have seen with a single agent. The anemia is, I think, most important to be seen there because we know that that has been the biggest lead in discontinuation of Jakafi, where in the COMFORT-1, COMFORT-2, it led to 45% of grade 3 anemias or more. With the combination upfront, it still represented the major grade 3 side effects, which was noticed in about 33% of these patients, still less than 45% as a single agent. So that's going to be the most important thing to be ruled out in the future, whether we're going to choose the combo up front, or we're going to do the add-on approach in those failures, or we're just going to use it as a single agent. I think all of them are very promising.